Today I am going to talk on immunology and pathogenesis in tuberculosis. So first part is the immunology of tuberculosis. I will discuss the immunology and pathogenesis of tuberculosis. As you know, TB remains a major global health problem with Mycobacterium tuberculosis, that is MTB, as the causative agent. The host immune response determines whether an individual develops latent infection or active disease. So let's begin by understanding the immune mechanism involved in tuberculosis. So first part is a innate immunity in tuberculosis. The first step in TB infection is the inhalation of Mycobacterium tuberculosis, which reaches the alveoli. Here the alveolar macrophages serve as the primary line of defense. These macrophages phagocytose the bacteria, but Mycobacterium has developed mechanism to evade the destruction. The evasion mechanism with Mycobacterium prevents phagosome and lysosome fusion, avoiding degradation. It resists oxidative stress and inhibits apoptosis, allowing persistence. So second part, that is the key innate immune cells. Macrophages attempt to kill Mycobacterium but often fails. DC, that is dendrite cell, present antigen to T cell and activate the adaptive immune response. Neutrophil and natural killer cell contribute to early immune responses but are not always effective. So despite the innate immune response, Mycobacterium often survives, requiring an adaptive immune response for further control. So now let's start with the adaptive immunity in tuberculosis. The adaptive immune system, particularly T cell responses, play a crucial role in controlling tuberculosis. CD4 plus T cell, that is a Th1 response, it secretes IFN gamma and TNF alpha, activating macrophages to kill Mycobacterium tuberculosis. Essential for forming granuloma, which restrict bacterial spread. Second is a CD84 T cell, directly kill infected macrophages, while perforin and granzyme. Third is a regulatory T cell, that is a TREX, suppress excessive immune activation, but in some cases they may contribute to persistent infection. So the B cell and antibodies play a limited role in tuberculosis, but antibodies may help with bacterial opsonization. So now the granuloma formation and its role. One of the hallmark of tuberculosis immunity is the formation of granuloma, which serve to control but not necessarily eliminate Mycobacterium tuberculosis. The granuloma consists of macrophages, epithelioid cells, and multinucleated giant cell at the center. Surrounding lymphocytes, that is a T and B cells. Fibrotic capsule that restrict bacterial spread, caseous necrosis. Over the time, the center of the granuloma undergoes necrosis, leading to either bacterial clearance or reactivation. Thus, the immune system play a dual role. It helps to control tuberculosis but also contribute to tissue damage. This brings us to the pathogenesis of tuberculosis. Now the second part, pathogenesis of tuberculosis. Stages of TB infection. TB tuberculosis progress through the distinct stages depending on the host immune response. First is a primary TB infection. Mycobacterium tuberculosis reaches the lung. It causes macrophages to engulf the bacteria, which results into granuloma formation. Most individuals control the infection, leading to latent tuberculosis, that is LTBI. Second is a LTB, that is a latent TB. Mycobacterium remain dormant within granulomas. The patient is asymptomatic and not infectious, means it is not transmitting the infection. Third is the active TB disease. Breakdown of granuloma leads to bacterial dissemination, that is the spread through blood or lymph nodes. Symptoms include chronic cough with sputum. It could be blood stick sputum or possibly hemoptysis. Fever, night sweat, weight loss significant, fatigue and breathlessness in severe cases. Miliary and extrapulmonary tuberculosis. If Mycobacterium tuberculosis spread via bloodstream, it leads to miliary TB, small nodule throughout the body. Extrapulmonary tuberculosis can affect the brain, that is a tuberculous meningitis, bones, pods, that is spine tuberculosis, lymph node and kidney. Mechanism of tissue damage. Tuberculosis causes lung destruction due to a combination of bacterial virulence, that is the resistance of the bacteria, and immune mediated damages. So first is the immune mediated damage. Cytokine like TNF alpha and IFN gamma lead to chronic inflammation. Caseous necrosis result in lung cavitation, promoting bacterial spread. Cavitary TB and transmission. Granuloma breakdown forms cavity formations, which leads to bacteria release into the airway that can cause infectious droplet spread tuberculosis. So Mycobacterium virulence factors ES86 and CFP10 help mycobacteria escape the immune attack. Mycolic acid provide resistance to immune response. Host pathogen balance and outcome. The outcome of TB infection depends on the balance between immunity and bacterial survival. Strong Th1 response leads to latent tuberculosis, that is a control, LTBI. Weak immune response leads to active disease, that is a disease progression. Overactive immune response leads to excessive lung damage. In immunocompromised patients such as those with HIV or malnutrition, the risk of dissemination TB is much higher. So, in conclusion and for the future perspective, to conclude, TB pathogenesis is driven by a complex interplay between mycobacterial, Mycobacterium tuberculosis survival strategies and host immune responses. Understanding this mechanism is crucial for developing better diagnostic technique, vaccines and treatment approach. So the key takeaway message is TB evades macrophages, killing and persists in granuloma. The immune response both control and contribute to lung damage. And the latent tuberculosis can reactivate in immune compromised patients or individuals. New therapies including immunomodulatory drugs and host-directed therapies are being explored. Thank you.